Afternoon, everybody. Thanks for joining today's talk. Today we're talking about personalized medicine with pharmacogenetic testing. It's a MyRx UF Health service, so I'm going to talk to you about that today. My name is Emily Cicali. I am a clinical director of MyRx, which is a UF Health service that is led out of the University of Florida College of Pharmacy. So I'm also faculty at the College of Pharmacy, so I'm super excited to be here today. So as you may know, about 75% of people won't respond to their medications. There's several different reasons. It could be diet, there could be drug interactions, missing the dose, and then your DNA. So pharmacogenetics or your DNA could be a reason for why people don't respond to their medications. It's just one piece of the puzzle because there's several different factors that are at play. So what is pharmacogenetic? So it's a DNA test, like I mentioned. So just like your DNA tells us if you can roll your tongue or if you have widow's peak, how many people can roll their tongue? Okay, so not everybody. So that's a genetic reason that can actually make you roll your tongue. Attached earlobes or loose non-attached earlobes is also another genetic factor. And so very similarly, we are looking at a specific part of your DNA that shows how you express enzymes in your liver. So your DNA encodes for proteins. Proteins is another word for enzymes or drug metabolizing enzymes. And so the enzymes that we're talking about with pharmacogenetics are expressed in your liver, and they're the ones that are responsible for either getting medications out of your body or actually activating medications in your body so that they can work. So when we're talking about these enzymes or drug metabolizing enzymes, they have really weird names. So they're called cytochrome P450 enzymes, or CYP for short. And it's, you say it like sip, like you take a sip of a drink, but it's actually CYP. And it's CYP and then a bunch of numbers and letters. So you don't need to necessarily, you don't need to know the different CYP enzymes or the CYP numbers and letters that I'm going to be talking about, but just know that that's a marker that we're looking for. And each CYP enzyme is relevant to different medications. And these CYP enzymes, what the DNA test tells us is the level of enzyme activity. So you can see here, you can have different levels of enzyme activity, anywhere from slow all the way to fast. And then that has implications on your medications. So you can imagine if you are somebody who has a genetic variation that makes your enzyme activity fast, you're going to get rid of medications more quickly in your body. And then the pharmacist or your doctor may recommend either a different drug or a different dose of that medication. So really, pharmacogenetics is a genetic DNA test. We are just looking at a portion of your DNA that predicts these drug metabolizing enzymes. So it doesn't look at your whole genome. And it tells us information on how you're expected to respond to certain medications. It's not all medications, but it is several different medications. All right, so let's go into these kind of slow and fast examples and what that means. So when we're talking about our turtle or our slow enzyme activity, that's going to give us a result that your DNA will tell us that if you're a slow metabolizer, your result is going to show on your report that you're a poor or intermediate metabolizer for a specific enzyme. And what does that mean? It just means that you're going to break down certain medications slowly or maybe not at all. And so you would result in then having this increased enzyme activity here. So when we're looking, we have an interactive activity going on. So everybody should have a card and pictures of these little guys. We're going to go into an activity in just a minute. When we're talking about fast enzyme activity, that's our rabbit here, our results are going to show as either rapid or ultra rapid metabolizer. So that's telling us that enzyme activity is fast. And it means that you're going to break down those medications very fast. And then in that case, you're going to have decreased sensitivity to medications. So this is looking at the drug concentrations in the body. On the right-hand side, we have what a normal individual would have, which is the majority of the population. And that's where we get our standard dosing, is based on the majority of the population, which correlates to being a normal individual or normal metabolizer. But then you do have these genetic variations that can affect 9 out of 10 people. So pharmacogenetic testing can help with consultations. So being able to interpret these results and applying these to certain medications can help with a wide variety of areas. Most commonly, we're seeing it for depression medications and anxiety medications. Pain medication is also highly relevant. There are certain medications prescribed like after surgery or sometimes long-term pain medications that we can predict if that medication will work for you based on your genetic result. People might take medications for stomach ulcers, different heart health conditions, heartburn, and all of those can be impacted by pharmacogenetics. And then 9 out of 10 people are actually going to have some type of genetic variation that changes how they would respond to a medication. So pharmacogenetics has been shown to decrease the chance of side effects. So this is just a generic figure here, but what it's showing is that in the red bar versus the blue bar, there's less occurrence of that side effect. So when you have pharmacogenetics, you can actually reduce the amount of side effects that occur by basically mitigating that and giving a different drug or a different dose. Specifically for psychiatry medications, when we look at pharmacogenetic guided versus usual care, we found that there's higher rates of depression remission in response to medications when you use those pharmacogenetic results, along with clinical factors. And this was in over 1,000 patients with depression. And you can see the differences in remission, response, and symptom improvement. And that usual care bar in this case is lower because this is looking at resolving those or getting to remission or getting to response. So specifically for psychiatry medications, these are medications for mood, depression, and anxiety. If anyone's been on this medication, you might know they take us several weeks to work. So if you needed one of these medication, your doctor will just pick one based on different clinical factors, one that they think will work well for you. And then it takes about 4 to 6 weeks to see if that's working. If 4 to 6 weeks, you go back to your doctor. If it's still not working, they might increase the dose. You have to give it another 4 to 6 weeks. It might still not be working. Then your doctor will switch the medication. And so really where pharmacogenetics can help is in this area. This is called trial and error prescribing, which is the standard of care. And so pharmacogenetics can help reduce that trial and error prescribing by giving your doctor more information up front to narrow in what medication might work best for you. So instead of starting you on drug X, which they might have done, we might now know that that one might not work best for you, and let's skip it and go right to the next one. Another area is reducing the risk of heart attack and stroke. So there's a certain medication given after you have a heart attack that will prevent an additional heart attack. So it's preventing preventing that blood clot. And so what this figure is showing here in the red box is that they're individuals who have a genetic variation that were given a blood thinner not guided by pharmacogenetics had the highest event rate versus those with a genetic variant given an alternative had a lower event rate. So we use this information to guide medication post-heart attack so that way you're on the right one to reduce events. This is our panel right here. We have a 7-gene panel that we test for here at UF Health. And our service, I'll tell you about it at the end here, but we interpret these results. So we take these results and we give your doctor personalized recommendations. You don't have to get testing at UF Health. Some individuals might already have testing. There's several different companies out there that are very good as well that all do panel-based testing that can guide all of these very similar medications. So you can see this is what I mentioned with the different genes and the medication pairing. So CYP2D6, that's that CYP enzyme. And then the 2D6 is just the naming of that gene that represents the drug metabolizing enzyme. So we would look at the pairing between the gene to guide the certain medications. So there are several different ones, mumble jumble of numbers and letters. You don't need to worry about that, but we just match them up and use that to guide these medications that are listed here on the right. So let's talk about CYP2C19. So CYP2C19 is a gene that impacts medication response. That's what we're talking about today. And these are those results. So that enzyme activity that I mentioned, these are the results that are going to come back on as a result of the DNA test. So it might say you're a poor metabolizer, intermediate, normal, or rapid or ultra rapid. And what that means is the level of enzyme activity that you have. So poor metabolizer is going to have little to no enzyme activity, whereas our rapid and ultra rapid are going to have increased activity. All right, so now this is where the activity comes into play. So everybody look at your cards that you have. You should have a different color. So anyone who has a red card, hold up your red card. Red or pink? Okay, so we have a few here, looks like about 3. And that's consistent because that's about 3% of our population is going to be a poor metabolizer. So these are individuals who have little to no enzyme activity. So in this room, we would expect about 3 individuals to be a poor metabolizer. All right, what about yellow? Who's got a yellow card? All right, so a little bit more. Yeah, okay, great. So intermediate metabolizer, these are individuals with still decreased enzyme activity, and it's about 26% of our population. All right, who has the green card? Even more, okay, great. So green is normal. So this is consistent with the majority of the population, but it's actually only about 40%. So 40% of our population is actually considered normal for this enzyme activity. And then last but not least, who's got a blue card? The blue index card. Okay. Perfect, great. All right, so that's about 32% of our population is going to be rapid or ultra rapid metabolizer, which means you have increased enzyme activity. So this activity was just to give you a visual on how prevalent these genetic variations are in the population. All right, so now let's connect that to the little guys that you have. So if we're talking about the individuals who have the red or yellow card, so these are individuals with intermediate or poor metabolizer, so decreased enzyme activity. And let's think about the connection between proton pump inhibitors. So proton pump inhibitors are over-the-counter medications that are used for heartburn. They can be prescribed if you have a stomach ulcer. You might recognize the names Prilosec, Protonix, and other acid-related medications. So these medications are broken down by CYP2C19. So that means they depend on CYP2C19 to get out of your body. So poor and intermediate metabolizers are going to break down these medications slowly. So which of these little guys do you think would result from someone who's being a poor or intermediate metabolizer? So you have a little guy on kind of either side of your papers. So just hold up facing me which one you think would result from a poor intermediate metabolizer taking Protonix, and that depends on that genetic activity. All right, so I see a mix here. So it's actually the more drug concentrations in the body. And so the reason is because these PPI medications, such as Prilosec, depend on CYP2C19 to get out of the body. So if you don't have that enzyme activity, it's just going to build up in your body. So the person is actually going to have more drug concentrations or more Prilosec in their body. And that could be good, but it also could not be good. So that means the drug is going to work better because you're going to be exposed to more drug, but then that might result in more long-term side effects if someone is using this medication chronically or over 3 months. All right, let's go on the opposite spectrum now. So someone who is a rapid or ultra rapid metabolizer who is going to break down that Prilosec fast. Which little guy do you think this scenario would be? Awesome. All right, you guys got it now. Yes, exactly. So now we have someone who's breaking down the medication fast, and therefore the drug concentrations in the body are going to be lower. So in this case, we wouldn't expect the drug to work that well. And so our recommendations are going to be to either increase the dose or take the drug multiple times a day, or potentially give an alternative. Another example of a drug that has to go through this enzyme, CYP2C19, is called Plavix. So this is that medication that I mentioned that is given after a heart attack. And this medication is different than that Prilosec that we just talked about because this actually has to be activated in the body. So you would take the drug in the form of a pill that's in that Plavix or clopidogrel form, and this is not active. So in pill form, when you take it by mouth, it is not going to thin your blood. Then it's going to get absorbed. It's going to go to your liver, and at the liver, it'll interact with that CYP2C19 enzyme activity and get turned on. And so once it's on, then it becomes active and can actually do its job and thin that blood. So this is what we would call a prodrug, one that has to be activated by this enzyme. So in this case, if we have a poor or intermediate metabolizer that we are depending on getting activated by CYP2C19, and in a poor and intermediate, they're not going to activate the Plavix, so it's less likely to work. Which guy do you think is going to result? This one's opposite of the other scenario here. So it's actually decreased sensitivity here. So in this case, we're thinking about the active drug. And so in this scenario, someone who's a poor metabolizer is not going to be able to activate the drug in the body. So they're not going to get to that higher concentration. They're not going to be able to get here because they're not able to activate the drug. So the active drug is going to be much less in their body, which means that drug is not going to work for them. So in this case, we're going to be recommending an alternative, because this individual's body is not able to activate the drug in the body, and therefore it's not going to work for them. All right, so now we'll go to a few patient cases just to showcase how else we can use pharmacogenetic testing. So this individual is seeing that we have a patient coming to their doctor. They had been trying Lexapro. It's been 3 months. They still don't feel any better. They have no motivation, they're frustrated, and the same thing happened with Celexa. So they're on kind of the standard of care of trial and error prescribing. They tried Celexa, then they tried Lexapro, and it's just still not working for this individual. So the prescriber here decides to refer this patient to MyRx for pharmacogenetic testing and seeing about getting an alternative medication that can be guided by genetics. So we get this patient tested. This is what these results look like. So we have all of our SIPs here, mumble jumble of numbers and letters. This is the genotype here. So how this works is one of these star numbers is from mom and one of these star numbers is from dad, and they get put together to be able to predict that enzyme activity. So in this case, this patient is normal for that CYP2D6 enzyme and ultra rapid for that CYP2C19 enzyme activity. So green for CYP2D6 and that blue card for CYP2C19. And when we're thinking about the medications for antidepressants, for depression and anxiety, these medications can kind of be split into which ones are metabolized by one gene and the other ones are metabolized by another gene. So in this case, these 3 medications that might be familiar to you all have to go through CYP2C19 to get out of the body. So in this case, this patient was ultra rapid metabolizer, or that blue card, and so therefore is going to have decreased blood concentrations in the body, and therefore we would not expect these drugs to work because the individual is not able to keep the medications in the body long enough for them to hang around and do their job. These other medications, however, are other alternative options that are metabolized by CYP2D6. And this individual is normal, so we're just going to skip it and go right to these medications, because since they're normal, that's that green card, we would expect usual amount of drug in the body, exactly what we would expect. So MyRx would be telling this doctor that we would want to choose a medication not impacted by CYP2C19. And so if the doctor didn't have this information, they might just be going down this list one after the other, because they're all typically equally efficacious. They're all like, one doesn't necessarily work better than others. There might be certain factors such as like age, weight, blood pressure that might make a doctor choose one of these over another. But typically, a standard of care, you could really just go down the line of these medications and try them in that trial and error prescribing. And that's what was happening with this patient. they had tried the Lexapro, then this Celexa, then maybe next the doctor would be trying Zoloft, and then it wouldn't be for another trial if they continued on that pathway that they would get to a medication that we would expect them to actually work. Does that make sense? All right, great. So this is just showing the frequencies of that CYP2D6. So we did the activity with the cards for CYP2C19. We're not going to do the activity for CYP2D6, but just to showcase that each gene, the variations are different frequencies. So in this case, our poor metabolizers for CYP2D6 is about 7% of the population. Intermediate metabolizers is almost 40%. Normal metabolizers is almost 50%, and then ultra rapid is about 3%. So you might think that 3% is pretty rare, which it is. However, it can sometimes have very significant consequences for certain medications, such as opioid medications, for example. So this is information that you would want to know ahead of time. So our next patient case here is talking about heartburn. So this individual is presenting, they've had heartburn, chest pain. It continues to get worse every time they lay down, and the Tums just isn't working. So the doctor says, like, okay, it sounds like it's acid reflux. We're going to start you on Prilosec. Let's also refer to MyRx and get pharmacogenetic testing just in case they need it in the long term and can help to provide just another clinical factor to guide this medication. So again, the results come back. In this case, when we're talking about these stomach medications, we're only worried about that CYP2C19 enzyme. So that's why this one is only relevant for this one, whereas when we saw with the depression medication, there was 2 genes that played a role. For PPIs or proton pump inhibitors, those stomach medications, we're just looking at CYP2C19. So our last patient case was ultra rapid metabolizer, but in this case, they're a poor metabolizer. So what that means is they got a non-functional copy of the gene from each parent, which makes them a poor metabolizer. So they have little to no enzyme activity here. And so when we're thinking about our proton pump inhibitors, so that's again the Prilosec, the Protonic, Prevacid, Nexium, these are all medications that are impacted by CYP2C19. And I didn't quiz you this time, but we have over here, we would expect increased sensitivity. So because this individual is a poor metabolizer, they're not able to get the drug out of the body. The drug, therefore, is building up in the body, and the patient is going to be exposed to higher drug levels. So the implications specifically for these medications is increased risk of side effects when used for greater than 3 months. So osteoporosis is one of those side effects that we're worried about. Hypomagnesium, different aspects here, bone loss. So we would want to either, once the symptoms are controlled, reduce the dose or get off that medication. Infection is another risk factor long-term with these medications. All right, so our next patient is someone who broke their elbow and they are feeling like they're still in pain despite being prescribed medication. So they're on Ultram or Tramadol. The only thing that's helping them is Advil. They're in a lot of pain and they just don't know what to do at this point. So another common scenario, doctor is very smart, says, let's go to pharmacogenetic testing and refer you to MyRx. So in this case, CYP2D6 is relevant for our opioid medications, and then CYP2C9 is also relevant for our over-the-counter anti-inflammatory medications. We're focusing here on the opioid medications. And again, this is someone who's a poor metabolizer. So that red card, they got 2 non-functional copies, one from mom and one from dad. So in this case, again, I'm not going to quiz you here, but this one is similar to that clopidogrel or Plavix in that these opioid medications depend on the CYP2D6 enzyme to get activated in the body. So in pill form, most of these will not work until they get to the liver and meet that CYP2D6 enzyme activity and get activated. So in our poor or intermediate metabolizers, and they just don't have that enzyme activity enough to actually make these medications active and make them work in the body. So that's this guy over here with the decreased sensitivity. I should have named them instead of just calling them all this guy. But the decreased sensitivity, so lower drug levels in the body because that individual is not able to activate the drug like a normal individual would, where they would get that normal drug concentrations in the body. So in this case, we would be recommending that the doctor prescribe an alternative medication. There's other medications that work similarly that don't go through that CYP2D6 enzyme activity that can be prescribed instead. All right, so we talked a little bit about MyRx, but what is MyRx and how does MyRx work? So MyRx is a UF Health service, and you can get referred by your healthcare provider, or you can actually self-refer and sign up for yourself, and then we'll work directly with your doctor to implement these changes. So you can have your healthcare representative either fax us a referral, email us, call us. If they're a UF Health provider, they can just electronically find us in the medical record and send us over a referral. If you wanted to sign up yourself, you can call us, you can email us, or you can go to our website and sign up online. So if you go to ufhealth.org/MyRx, this is what that website will look like. And then you click over here, this register for MyRx. There's a lot of good information on the website. Feel free to browse around. There's a video that gives you more information about pharmacogenetics. And then you can click register, which will take you to a secure patient portal where you can put in your information. So once we get your registration and your order placed, you have the option to conduct testing through us, or you can provide us results that you already have. So if you already have test results available, 9 out of 10 times we can take them. We'll usually take a look at them and make sure that they meet our criteria for what lab, like we just make sure it's a good test. But you can get tested anywhere, or we can help facilitate testing if you need it. Testing can be done with a cheek swab, or you can do a regular blood draw just like any other lab test, and you can go to a lab draw station if you're a UF Health patient. If you want a cheek swab, we can mail you a test kit to your home. If you're interested, we actually have some test kits here today. If you're a UF Health patient, this is what it would look like in my chart. So the results come directly back to you as well. So you can see, you'll see those genotypes, they don't mean a lot, but you'll see those phenotypes that we talked about. So a rapid metabolizer, ultra rapid. And then there's some information on the drug level too, to let you know what drugs are actually impacted. After your results come back, we would set up a virtual visit with one of our pharmacists. We do visits over Zoom, and we go over your results and we give you education. One super important thing about this test that I did not mention is that these are lifelong results. So they are not going to change. So you just need to get tested one time and you can continue to use these results. So it can really inform your current medications. It can help explain maybe past response to certain medications, and it's there if you need them in the future. This is why we do a panel test, because maybe you're getting tested today to guide your depression medication, but then in a couple of years you have a surgery and you need it for that pain medication. It's already available and you can continue to reuse those results. So that's what we really spend a lot of time on the visit doing, is really educating you what your results mean, what medications are impacted. Because if you're a UF Health patient, that's great, everything's in the medical record. But if you were to go to another doctor, we really want you to be able to recognize what medications are impacted, because not every this is not at the top of the mind of every single doctor. They'll know of it, but it's not common practice. So we really empower you, once you have tested that, here's your test results in hand, and bring them to your other doctors. And this is an example of the patient education that you would receive. So we go over, there's just like a reminder about what genetic testing is. These are the different results. So you can see again, those like the metabolizer status, so intermediate, and then explanation of what that means. So normal or decrease, that'll give you that explanation on your own report. And then by medication, we talk about by area here. So this will tell you what medications are impacted and the potential response. But the specific medication recommendations will go to your doctor. So it's up to your doctor to implement the medication changes. We don't want you to make any changes on your own. This is just information for you to know and to be aware of, and then a conversation between you and your doctor to say, should we use this information now, and let's make these changes at this time. And then lastly, the recommendations also get sent to your provider. So even if you sign up for yourself, we'll make sure we have your provider's information available. They'll get a fax consult note that's really detailed. I have a picture of that over here. It's really detailed for your provider. It tells them information on what these results mean, specific recommendations to you, because we learn more information from you during that visit. We're going to do what we call MyRx. So we're going to learn about your past response to medications. We're going to learn about other clinical factors that are going on, and we'll put all those pieces together to make a really specific recommendation to your doctor. So there is a cost associated with this service. It does cost about $199 for most patients. Like I mentioned, we do have test kits available today. So if you want to sign up today, we're offering $50 off that price. But there's two fees associated with the service. So there's the test and then there's the visit. This $199 piece is a cash price that is for the visit. The test itself is billed through insurance if you'd like. And we've seen about 75% of the time that test will be covered by insurance. If it's not covered, we work directly with your insurance to appeal claims. So if it's denied, we'll provide letters to your insurance company, and we do really thorough job trying to get that covered. And as of next month, actually, there is new legislation that's going to be requiring this type of test to be covered. So I imagine over the next year or so, we'll see that rolled out across several different insurance companies, which is a great thing. So all goes well, it would cost about $199 for most patients. If that test is not covered, the maximum out-of-pocket cost is $393. So in total, it would be a $600 fee at most. But again, it's a lifelong result that you can continue to use. So it's a one-time test, a one-time fee, and then you have this information, and we're always available for additional questions directly to you or to your provider. So you can visit we have a booth here. We have some test kits available if you're interested. But really this test can help explain the past, inform future or guide your current medications, and then guide any future medications. This is our contact information if you have any questions.